we're starting now.
Okay.
Okay. How you smell? Dr. Jabara, please introduce yourself.
I'm Sammy Jabara.
Yes.
I'm a physician, reproductive endocrinology and fertility doctor, board certified in REI. I've been in practice for about 17 years. I did my studies, my training at the University of Pennsylvania in Philadelphia. And then I helped set up a lab in Texas, Texas Tech, where I worked there for several years. Then I moved to LA and helped set up a couple of clinics for an insurance company here in the West Coast. Currently still working out of these offices and work also out of Beverly Hills and basically do all the assisted reproductive technologies like in vitro fertilization, but also egg donation, surrogacy, artificial inseminations. I do also all the surgeries needed for any woman or man who are about to embark a journey for pregnancy. Also treat other families as well, and anybody who is wanting to form a family.
What makes you want to become a reproductive?
It was like something that when I was in college, before I even started medical school, I was sitting through a lecture of where animal physiology, where the professor was explaining about the egg and the sperm and how it develops into an embryo. And I was extremely amazed at how we can do things at such an early level of life and help with, life and helping with forming life. Of course, nature is amazing itself, but to be able to help those couples, that became an initial thought of mine, and the focus was what do I need to get to do that? Also, I liked the specialty in general when I became in medical school because it was at the edge of both being a surgical specialty and a medical specialty where you can use your brain and at the same time do surgeries and technologies, and at the same time be at the edge of technology. It's always interested in technology, always thought that technology and medicine are one, and our field is one of the most advanced fields as far as using technology to help men and women. So that's why I like it. I like it because it's a surgical field, it's a medical field, but it's also a technologic field.
In your 17-year in this practice, what is the most touching moment, something that you know?
There's a lot of touching moments, but it is extremely, I would say, rewarding when you see couples that are trying for so hard and so long, and finally they come after everything is done and said and done. They come to your office with the baby and some chocolate or a bottle of champagne or some flowers, and they come in and they say, "This is what you did. Look at this. This amazing boy or girl of mine wasn't going to be here if it wasn't for you. So you changed our lives. You made us, you made us have our own family that we always dreamt of. That's how we imagined it." And that has happened many times, different levels, and it's touching every time it happens. Of course, some people are more emotional than others, and I remember a couple of times where I felt very drawn to that, and I felt extremely moved, and I felt like I've really finally was able to accomplish exactly what I was looking for, which is to help all these people. But it doesn't resonate until you find somebody that really puts it in your face and shows you what you did.
As we see with the newborns.
Yes.
Is there any specific case you'd like to share that was?
Case of There's a lady that worked as a singer and was very, very much into music, and husband was into music, and she was having a lot of miscarriages and wasn't able to maintain the pregnancies, and finally was came and had done some cycles somewhere else and wasn't able to maintain the pregnancy. When she came to me, I did a lot of testing on her, and I found out that she had severely diminished ovarian reserve, very few eggs, and I was explaining to her how difficult it is at that age, which she was in a more advanced age, that we were able to make it. And she said, this is such an important thing for me. I want you to work with me. I told her your odds are probably 1% that things are going to work. And we worked with her for 3 to 6 or 4 months or 5 months, and the result was very positive. And she was able to get pregnant and not miscarry. That particular lady did a specific song about this, and I'm very sensitive to poetry and to music, and the words that she used, and like everything she said in her poem, and the way she sang it. She had a beautiful voice. I felt very specifically. I felt that was a very special moment in my life. So I'm sure there's a lot of other cases. Other doctors save lives, and we don't have that in my field. We don't save lives, but we help people bring in new lives, bring in new families, create new families. Every moment is a special moment, and that's for real. Some more memorable than others.
Oh, great families, great lives.
Yeah.
So what is your experience with our egg bank, NC egg bank?
It's a very good experience. NC was introduced to me actually initially through some physicians that I knew, but also through a patient who specifically have been kind of wanted to have a specific procedure where you would actually be able to help her with. And I said to her, I absolutely have heard of this bank, but let's have this first-hand experience with it to see if things work. She was treated very well, and she was helped at different stages of her treatment, and was updated, and I was updated. And the bank was not just interested in, and the lab was not just interested in giving her and providing her eggs or embryos, but also the development of everything and the success that it happened, but also the compassion that was provided during the whole process. That was one of the main encounter. Since then, I've had many other encounters with this bank, and I've referred a lot of people to the lab, to the egg bank, and to the fertility services. I've also had a very, very very good success, but also very good comments and reviews from patients who told me, "Thank you, doctor, for helping me achieve that." The truth, you would ask me, why would I even refer them there? It's because I wasn't able to provide in my practice all the things that they were providing. Particularly, this particular patient, one of them was, for example, wanted egg donor with something that fits her background, and it was amazing the amount of choices she had and the ability to get good quality eggs and good quality embryos after that, be tested to make sure those embryos are normal or not. The lab has been known in the area in Los Angeles and in the West Coast for being a very good lab for a while. So people trust it. big major universities like UCLA and USC, particularly UCLA. I've had, when we go to the journal club locally here and we discuss things, the physicians that practice there, but also the lab itself has given people inspiration about being confident on new technologies like pre-implantation genetic screening, PGD, PGS, PGT, and was because of their high success rates. And since, of course, a lot of the physicians that work there and the lab technicians and the doctors in the lab that work there are pretty much reputable, people would actually follow their lead in the area and do things, try to, they would be more trustful of a certain procedure because of what they've done. So they were innovative, they were avant-garde, more at the edge of technology, and very successful early on before other people were successful. I feel like I'm dropping this one. Yes. Yeah.
Next, I'll ask you about our embryologists and also our
Dr. Wong?
laboratory. Yeah.
Yes.
So how you think and what's a critical,
What's what?
what's critical about a laboratory? And
Okay. So the thing that distinguish the ANSI laboratories and the laboratories that are affiliated with ANSI from others are going to be mostly the amount, first the experience of the embryologists, vast experience, volume, how many cases they've done. Number two, the amount of precision and accuracy and no compromise, presence whenever need to be present on a Saturday, on a Sunday, on a holiday, presence, accuracy, and as far as using equipment that is up to date, incubators, microscopes, XCs, laser, whatever it needs to be done to do all the procedures that are done. The actual equipment that is used is up to date, and so it's a precision of the personnel. It's their experience that makes it's the culture media that they use, the everything that is done on a manual technical level, but also on a equipment level is what distinguishes that lab from other labs. So I think it is it has to deal. The labs is half of what we do. The physicians have only the ability to have the management of the plant, extract the eggs, the sperm, but then after that, what happens in the lab is what's going to determine the success. So the physicians are going to be responsible for 50% of that success, and then the lab is going to be responsible for that other 50%.
Can you talk about the new technology and the possibilities about our, advanced technology in reproductive medicine?
Yeah. So right now there's a lot of possibilities in reproductive medicine. Reproductive medicine always was at the very, very, as I said, one of the reasons why it was I selected that field is how technologic it is. And what happens is that technology evolves on top of technology. So it becomes even faster and faster as things progress. So for example, right now, there is a lot of gene therapies that is happening, and people are talking about gene therapies. There is something called, there is an actual, there's a modification of genes whenever there is abnormal genes, specific thing called CRISPR. That is currently a focus for the future as far as whenever we have abnormal embryos, what do we do? Do we just try to get the normal embryos or settle for egg donor or sperm donor, or can we fix the embryo? So this is one of the new technologies that are about to happen. It's not commercially available and it's not allowed yet in the United States because of many regulations. Other technologies that are currently available that people are doing already, as you know, pre-implantation genetic screening, but also screening for selective genes, and for, in addition to sex selection, in addition to screening for translocations, mutations, all kinds of abnormalities that can happen in the chromosomes, but also on a one single gene level. So this is what's already happening, but what is happening in the background and might soon be adopted at some point in time would be things like gene therapy or alteration of those genes to make something that's abnormal normal.
Very interesting. Also, can you share your proudest moment of your career? The proudest moment of your career?
The proudest moments is always whenever I go anywhere. I would be parking in a Beverly Hills shopping center, and whether it is somebody that works there or is somebody who's passing by, a client passing by, and all of a sudden sees me, and I would be with somebody, a friend or a family member, and they stop me and it says, "Doctor, this is," and they would start shouting and proud and and usually this is a very private thing and people don't share it with other people, but they would shout and say, "Doctor, look, this is my son and he's 3 years old and you had something to do with it. You're the one that caused it." And their husband would be standing there, and sometimes it would be funny, like, "Well, doctor, this is yours. You did it." I'm like, "No, it's your husband. I helped you do it." So that's one of like the funny moments. It's also a proud moment because anybody who's with me would actually see how, you can tell in their eyes how excited they are, how important this is to them. It makes me very proud to see that. But on an administrative level, I'm very proud that an academic level, I'm proud to be to have published and contributed to science, but also administratively contributed to setting up 3 clinics in the past and making it happen with not necessarily always a lot of resources. The third time it was with more insurance resources and other resources, but even the first time when it was at the university program, it wasn't a lot of resources, and I was able to set it up and make it happen, train the nurses, set up the lab. So that is a proud moment when I look back, and everybody would then, it becomes a big place. There would be many doctors, and then when that happens, I start looking back and says, "Do you remember when we did this, when we were only 2 people, just the front office and myself?" And so that makes me proud from an administrative standpoint. So
let's ask a little bit about your personal side. What do you like to do on your hobby and your personal time?
well, as you could see, I don't know if you could. I mean, I don't know how the video shows, but I'm currently in the area where I live, in my home, and so I am close to the ocean. So I like a lot of aquatic activities. I mean, I am very much love whether it is just simply to walk on the beach or or swim and surf, hike in the mountains. The mountains here are beautiful. I love to travel. I love international food, music. Love to experience people from other cultures. I am myself from basically, I grew up in another culture. My mom was grown in a continent. My father was in a continent that was raised in another continent. And my patients come from everywhere. So I am really excited every time I meet somebody from a new country or from another place. And I'm very sensitive I'm sensitive to cultures. I understand them. I understand women and men from other cultures and how they think and why they think that way. So my hobbies, it is to read about history and cultures as well, and because I feel like it enhances my understanding of the world in general, but also of what I do, so it helps me professionally. Okay.
Also give them professional.
The hardest thing in our field is to okay. The hardest thing in our field, and the thing that takes the most time, is not actually to do the procedures. So doing the procedures, it becomes, for a doctor who does hundreds or thousands of cases, it becomes kind of like you drive a car. It's not, I mean, of course there will be more challenging cases than others, but that's not what's hard. And that's not what takes the most time. What takes the most time is counseling people and giving them expectations. But also doing that with positivity, optimism, and compassion. So to equilibrate the actual truthful expectation of someone, what is the potential for them to be successful, knowing that there's a lot of unknowns as well, to be able to predict that, and at the same time to remain hopeful and positive and optimistic. And also be concerned about somebody, because some patients are able and don't have financial restrictions, but most patients have financial planning and financial restrictions. To be able to do all of that planning with the compassion and the understanding of what goes into that, that is the hardest part. So when somebody comes in and happy to be in my clinic or in your clinic and any other clinic, and they're spending a certain amount of money and they think that, you know, that's going to work. The question is always how to prepare the patient for understanding their true success rate, and that should be an honest, and this is really dependent on not just the physician expertise and the lab they're dealing with, because that determines the percentage, but also the relaying the message correctly. So being honest in our field is very important, but at the same time you have to relay the message in a kind way that does not make people depressed, because the psyche affects the things we do as well. And so I think management of expectations and explaining to every couple what their true potential is per cycle or per year or per month is very important. It's probably the most difficult thing we do.
That's about it. Anything else you want to add?
No, I thank you so much for coming here. I believe if you want to, so I really believe in what NC Bank and Practice and Lab and all the affiliated practices are doing. I believe that when you invest in technology and in people, in good people, you get very good results. I believe that that this company will continue to be very successful, and that the patients that have to deal with this company are going to be happy because they are dealing with the best not only locally, as in Los Angeles, and Los Angeles is a very big place, but also on the West Coast, and perhaps one of the best in the U.S. as well, and maybe potentially, since the U.S. has incredible statistics in the world of fertility, then you can extrapolate and say one of the best in the world. I do thank the opportunity to speak about that from personal experience with my own patients, with patients that have failed multiple cycles in the past and have been able to be successful when they were sent to your practice. So,
or should I move this over? Yeah.
So your father was a very well-known and well-respected IVF doctor.
Mm-hmm.
How do you think that he guided and inspired you? What kind of legacy do you want to carry into the next generation of the practice? And what do you want to do differently than your father?
Sure. So my father was a reproductive endocrinologist at a time that the field was truly in its infancy. So pregnancy rates in general were lower because the technology had not advanced. And so he had to figure things out on his own to try to maximize his patients' success rates. What drew me to medicine was seeing how happy my father was, and he'd come home and tell us stories about miracles, where he's able to help people have babies. And so, when I went into medicine and eventually reproductive medicine, my goal was to improve as best as I could upon the legacy, the foundation that he built. So luckily today, the technology in reproductive medicine keeps advancing, and it keeps getting better and better and better, giving us the opportunity to really improve outcomes for patients. And so really, I would love my legacy to be that I've carried on my father's kind of foundation that he built, and making it even better, and being able to provide fertility care for all people, regardless of gender, ethnic background. Really, anyone from our perspective should be able to have a baby.
Yeah.
I'm not doing very well on mine.
But it's okay. Everything is supposed to be natural. So, to add on, ready?
You ready? Yeah.
To add on to that question, I have a silly question to ask you. Why do you think people want babies?
That's a great question. I think people want babies for different reasons, but ultimately, I believe that people want babies because it carries on their family's legacy. People are motivated by seeing a piece of them move on generation after generation. But what I tell patients and what I tell friends who have babies is, it is the hardest thing you'll ever do, but it's also the most rewarding thing you'll ever do, raising a child. It's an incredible experience, and one that if people are interested in, will bring tremendous satisfaction to their lives. So it's an honor to play a small part of that in helping people have families when they otherwise would struggle or have difficulty being able to.
Yeah. So you have done a lot of fertility work for same-sex couples. Any stories from your practice that can resonate particularly well with the LGBT community?
Sure. I have numerous patients, male and female, who are either in same-sex relationships or are single, who want to start a family and have children of their own. And it's incredibly rewarding to me and my colleagues to be able to provide that kind of care for all our patients. Every story is unique and beautiful, so I don't have a specific story that stands out over the others. But just the opportunity to help people have babies when they otherwise couldn't, and being able to provide the types of resources that they don't otherwise have in order to have children is incredibly satisfying to us, and it's a very high honor for us to be able to do that for them.
Sure, and what kind of resources when you are talking about?
Sure.
Like what's their options?
Yeah, so for example, if you have a single male or a male in a same-sex relationship, in order to have a baby, of course, they would need donated eggs, and they would need someone to carry the pregnancy for them. And so we provide them with a wide variety of egg donors that they can choose from. And these egg donors have been medically and psychologically cleared and are doing it for altruistic reasons, and provide a very high likelihood of actually creating a good quality embryo that becomes a baby. Once that process happens, the intended parent or parents will then need someone to carry the pregnancy for them. And so we also provide them with connections to surrogates, or gestational carriers we call them, that have also been physically and psychologically cleared and are also doing this for altruistic reasons. And they usually have excellent pregnancy histories, so they were able to maximize the ability for these intended parents to have children. For single women and same-sex couples that are women, they will need donated sperm. And quite often the women want to carry the pregnancy themselves, but if they don't as well, for whatever reason, or if they have a medical reason not to, we can also provide surrogacy for them as well.
Okay. And have you ever in your practice that the surrogacy, the intended parents, they build like a relationship? I mean, like they still keep in touch even though the baby was born, and have you ever heard stories like that?
Yes, I get contacted by my patients, both local and international, all the time with updates, especially now with social media. You're able to connect very easily with updates monthly or yearly, how their baby's developing, and they're all incredibly thankful, and it really brings joy to my heart to see that.
Sure. And another question. So, can you think about one moment that is you are most proud of your career so far?
Well, actually, there's a picture up on the wall of the one time in my entire career that I got to operate with my father. My father retired back in 2007, and I had just returned to Southern California after training at Cornell for fellowship, and had one opportunity to operate with him before he retired. And that's a picture of that moment. And I have many proud moments in my career and in my life, but that's a particularly proud moment for me as it relates to reproductive medicine in particular.
That's very nice.
I need to itch. Sorry. Thank you.
So, as a doctor for IVF, what are the most common concerns that patients may have, and what are the most misunderstandings?
Yeah.
How have you learned during your practice to communicate with them,
Sure.
especially for those misunderstandings?
Sure. There are many variables that can make a patient's particular situation easier or harder to get pregnant. What I do for every patient, and I believe what my colleagues do as well, is we'll gather their medical history very carefully. We'll take that down very carefully, and then we do a very careful ultrasound and physical examination so that we can tailor each treatment to that particular individual and make it the most ideal treatment for that individual to maximize their chances. Some of the misconceptions are either that it's easy or that it's a guarantee, but medicine is very humbling and has taught me over the years that there's no such thing as a guarantee. But sometimes when we think it's also very difficult or near impossible, sometimes we overcome that, and there are what seem to be miracles in our field as well. So medicine is very humbling. We do our best for each and every patient. We tailor the treatment specific to that patient, and then hopefully it works out for all of them. But we counsel our patients not only of what can happen in a good way, but also of all the risks going through it so that they're well informed as they go through the process. I hope I answered that question well.
Yes, it's a lot. Yeah.
Okay.
And so at the end of the day, we're enabling new life to be born. What makes life beautiful to you? Outside of work, outside of everything, what makes you happy ultimately?
Yeah, this is an easy question to answer. It's my family, and I'm incredibly lucky. I have beautiful children. I have a beautiful wife. We all live very safe, healthy lives. We feel incredibly blessed, and going home every day and seeing my family, to me, is by far the most rewarding.
Can you keep going about, probably you talk about you have like Andrew is still a baby, and just tell us.
Yeah, so my youngest is only 8.5 months old, and the first time he smiled, the first time he laughed, the first time he started crawling, all these milestones were really special to us. But for me at least, what really melts me is whenever he smiles at me. When I come home, he looks at me and then gives me that warm smile. It'll solve every problem. That alone, it makes everything else not matter. So I feel very, very lucky.
Yeah, and what do you do with him when you are not at work?
So we'll go to the farmer's market. We'll go jogging in the jogging stroller. We'll sit at the table together and have conversations. We'll play on the ground. I love teaching him, numbers and words, and showing him pictures and reading books. It's beautiful. It's incredibly rewarding to raise a child.
Yeah, and we've heard that your wife is actually in the same field of your specialty.
Mm-hmm.
And can you tell us a bit more about her?
She is, and she's brilliant. She loves what she does as well. She's incredibly well trained, coming from UCSF, and is now at UCLA. And it's really wonderful for me to be able to have conversations with her and vice versa, where we completely understand each other and how to help solve problems for patients. We'll help each other in that regard. Sometimes there's some very challenging situations, and it's really nice for her and for me to be able to bounce ideas off each other in order to maximize patient care.
Yeah.
它需要加一句就是 my wife
哦
在前面，因为我不知道到时候用的时候，因为你说的。
哦，对。Can you say the sentence starting with like my wife? She is also IVF.
Yes.
Like that, because your voice doesn't have the part starting with my wife. She is also IVF.
Okay.
Yeah. Can you say that?
Yeah, and then you'll cut it off.
Yeah,
And then
we'll
you-
cut it off. I was gonna ask you like, what does your wife do?
Okay.
Yeah.
My wife is actually also a fertility specialist, just like me. She does IVF and all the fertility care that we do here.
That's great.
Great. 往下还有吗？
没有，我其实没有问题了。我想让他把那个照片拿出来说一下。
那个等会儿随采，就是现在你让他再说一说，就跟那个 Doctor 那个S 似的，他说一说，就那个女医生。Brower 对，他所有的那个流程能不能让他说一遍？
Okay.
因为他也需要演那些。
Okay, so can you talk about more about what will a patient comes in and what will she expect during this whole procedure of treatment?
I'm confused. Sorry.
一步一步的。
Like you just talk about the procedure, like the patient. I first see the patient and they'll do an initial consultation where I talk about
The process.
and then you just walk through us.
Sure.
Yeah.
So when a patient comes to see us, first we'll take an initial consultation. And sometimes, depending on where they are, if they're international, we can first start with a WeChat consultation. But eventually, when we see them in person, we'll do a very careful ultrasound and exam, make sure we have the full history. And then we're able to create a treatment plan for them. Once the patient starts treatment, they first start with blood work and an ultrasound. And once that clock starts, it's roughly, we'll see them every 3 to 4 days initially, then every 1 to 2 days, until their eggs are ready based on what we see on ultrasound and blood work. We then give a different injection in order to mature the eggs, and then under anesthesia, while the patient is comfortable and asleep, we'll take the eggs out of the body and fertilize the eggs in the laboratory to create embryos. From that point where we take the eggs out, 5 to 6 days later, we have embryos for testing. We do the test on the embryos, freeze the embryos, and about a week after that, we have an answer. So the patient themselves takes about 8 to 10 days of injections, and then the egg retrieval 2 days after that. So within 2 weeks, the patient's treatment is done. 2 weeks later, we find out what kind of embryos they have, and hopefully some normal ones in order for them to have a baby.
Sure. And some people may have concern over the actual surgery. Can you talk about how the OPU is being performed?
Sure. So we are extremely careful how we perform everything at our center to maximize patient care but minimize risk. So what I counsel all patients is that the risk with the egg retrieval is there are very rare risks, less than 1% risk of things like infection, bleeding, allergic reaction to anesthesia, and injury to other organs. These risks are minimized in skilled centers and skilled hands, but there's no such thing as a risk-free procedure, but we do minimize risks. For example, when we do the egg retrieval, my goal is always to place the needle into the ovary only one time and try to take the fluid out from each follicle while keeping the needle within the follicle and not going in and out several times to minimize risk of bleeding and infection. So I'll poke the right ovary once, the left ovary once, and hopefully get all the eggs from each ovary with just one poke.
It's very nice.
Yes.
Yeah.
OK，
那我们现在赶紧演完会议。
对，让他先去处理他的事情吧。
Because you have a balloon removal soon at 10:45.
Okay.
But so why do you love what you do? You could have been any kind of doctors. Why did you choose fertility? Tell me about the moment that you realized this is gonna be your life's work.
I think that I realized I wanted to do this the very first time I ever saw an egg retrieval. I was in medical school and I did a rotation with a fertility doctor, and the very first time I saw her do an egg retrieval and pass the egg through the window in the wall to the embryology lab, I just thought that this is definitely what I wanted to do. I think that it's starting your family, having a family is the most important thing that people do in their lives. And, other than surviving cancer, I think it's probably the thing that people care the most about. So I enjoy being part of that journey for people to be able to, create the families that they want to create.
Yeah, and to add on to that question, I have a silly question. Why do you think people want a baby?
Why? That's a good question. I think that probably evolutionarily there's just a natural drive to want to procreate, and then I think as a mother, you just think about all the things in your life, and the most important thing, the thing that brings you the most joy is your family, is your children more than anything. So I think that the desire for most people, not all people, but for most people to have that in their lives is very strong.
Yeah. So you yourself had children with IVF, 2 of them.
Yeah, that's true.
Can you tell me about the experience from a mother's perspective first?
It's a hard thing to experience, to want to be able to start your family and not be able to do it. I think is probably one of the hardest things that people experience. It happens at a time when everybody around you is also having children, because it's typically happening when your friends are all having babies. It's an isolating experience. People don't talk about it, and it's a very, very hard thing to go through. So as a patient, I know that and have experienced it, but I also experience it every day with my patients. You don't have to have had infertility to experience that with your patients and to know and understand how challenging it is. I think any compassionate doctor who takes care of people who have infertility understands how hard that it is for these patients to be experiencing this in their lives. So I think that, although my experience is unique as I've been on the patient side and the doctor side, I really do think that any compassionate physician understands how difficult this is for patients to experience.
Yeah, so then as a physician, as a doctor who will treat people that are not gonna be conceived on their own easily, what should they expect? Like, how do you usually start this process? What are they experiencing?
So typically what happens is that there's an initial visit where we gather a lot of information. We try to understand, you have a consultation where we try to understand, what your situation is and what your history is and what your partner's history is, and explain to you sort of what to expect as far as the next steps in evaluation and what all of your treatment options are. If the patient hasn't had an evaluation already, then typically we'll start to evaluate, potentially the reasons why they aren't getting pregnant, evaluate the sperm, do an AMH and an ultrasound to assess the quantity of the eggs, try to get a sense of the uterus if there's any issues there. Sometimes patients have already had that evaluation when they come to their consultation, at which point we sort of review that with them and help them try to understand if there is an identifiable reason why they're not getting pregnant. And sometimes there is, and sometimes there's not. Sometimes, there's obviously something going on that's preventing them from getting pregnant and you just don't know what it is. Then typically we would walk a patient through, at the same consultation, what their options for treatment are. And then, once the patient or partner have decided what to do, then we get organized to start whatever treatment they decide to do. If a patient's starting IVF, we sort of do some pre-conception optimization, make sure that if they need to be on any supplements or vitamins, that they're taking all of those things, if they have any medical conditions, that those medical conditions are sort of optimized. And then, all treatment cycles start with a period. So once a patient gets her period, then she starts a treatment cycle. And if she's starting IVF, oftentimes that will start with a short course of birth control pills, sometimes not, but a lot of times it will. We do ultrasounds and blood work to make sure everything is optimal to start injections. And then with IVF, a patient is on injections for about 9 to 12 days. So they have a visit here where they get a lot of instructions on how to use all the medications to make sure they're very clear on being able to use all these injections at home. And then once they get the green light to start the medications, then they get monitored really closely. They come to the clinic every couple of days for ultrasounds and blood work to monitor how things are developing. And then eventually, based on how everything develops with the eggs and the ovaries, then eventually they get a procedure called an egg retrieval, where we take the eggs out of the body. The day of the egg retrieval, they get anesthesia. They need someone to be with them all day. The partner needs to be here to give sperm, or there needs to be frozen sperm here. The egg and the sperm get put together the same day as the egg retrieval. And then the patient goes home and rests and sleeps, and then we watch the embryos develop in the lab for about 5 or 6 days. And then after that, if the patient chooses, she can genetically test her embryos, take a couple of cells off and send them for testing. And if there's normal embryos available, then the following month is when we get ready for an embryo transfer. Typically all the embryos are frozen about 5 or 6 days after the egg retrieval. And that's sort of just kind of an overview of how everything would work from the consultation to the embryo transfer if the patient were doing IVF.
Okay, so say.
能用上那个动一下那个屏，就现在变成待机状态。不是，画面。
Right.
刚才那什么角度？没事，可以，角度没。
Continue. Let me think another question. Okay. So for the injections that we are doing once we start the stimulation, do you recommend doing this at home, or do you have a way to have them come into the injections? How painful this whole process is, or is that too much work?
It's not painful. Some of the injections burn a little bit while injecting them. Most people feel comfortable doing the injections at home. We give you very detailed instructions, and we have videos that they can watch. And most people feel comfortable being able to do the injections in the comfort of their home. Occasionally there's a patient who just doesn't want to, just can't, doesn't feel comfortable doing it, and either they can have their injections in the clinic, or they can have somebody come to their house at night and help them with their injections. But again, I'd say 98% of people, once they receive proper instruction, feel comfortable doing the injections at home, and they're not particularly painful.
Sure. About the injections was one concern that some patients may have, some reservations they may have when they come through the cycle. What do you think there's other common concerns people may have about this whole process? What are the common misunderstandings people may have?
Yeah, I would say concerns, I think a lot of people are concerned about how they're going to feel, okay? People are concerned about what the outcome is going to be. So, I think most people tolerate the injections quite well. The more common side effects would be fatigue. Hopefully, as the ovaries start to get large from the injections, there can be some cramping and bloating, but overall, most people tolerate them just fine. And then it's just scary, you're starting this process, you don't know how you're going to respond, how many eggs there's going to be, how many embryos there will be. So I think there's this underlying anxiety throughout the whole process of the unknown and not knowing, how ultimately what the outcome is going to be. And I would say the most common misconception is that, we're always talking about losing eggs, that females are always losing eggs throughout their lives. And I think most people think that if we get 10 eggs or 15 eggs or 20 eggs at the time of the egg retrieval, that somehow they're worse off as far as their egg numbers at the end of the cycle because we've taken all those eggs out. But the reality is that you're not any worse off, and there's no long-term negative impact on fertility. In any given month, there's a group of eggs that are available to be stimulated. And if you don't take any medications, you'll have one egg that grows and everybody else will die. And if you take all these medications, hopefully everybody grows. So you don't lose any extra eggs from having done the process. And I would say that's one of the things that people ask me about all the time, is a sort of common misconception.
Sure. So you are young, you are very driven, and you have one of the highest success rates in the industry. What is powering you? What pushes you to work so hard?
I think I'm just naturally a hard-working person. I always have been. I'm a perfectionist, so whatever it is that I decide to do, I can't help but want to do it well. So, this is what I've chosen to do, and I wouldn't want to do anything other than my best in doing it. And I like what I do, and I think the work is important. Like I said, I think that helping people start their families it's one of the more important things that you can help people with in the world. And I just think that if you were receiving care, you wouldn't want someone taking care of you who didn't care and didn't want the best for you also, again, because it is something that is such an important part of their lives. And, when people come back, I've had patients deliver their babies, and the first place they come is back to the office to introduce their babies to us. And I get a lot, we get a lot of emails and cards, and people will email me from the hospital to tell me that their baby's here, and you just think, wow, how did you even remember that we were part of this process? But I think that there is a sense that you really impacted their lives. They don't forget. Yeah. So.
So what was your proudest moment in your career?
I don't know if there's there's no one proudest moment. Every patient that graduates on pregnant, you feel good about it. You don't feel, some of them are more challenging. Some patients come in and do one cycle and get pregnant right away, and some patients you're taking care of for years and years and years before they move on. So certainly there are some patients that when they graduate, you feel a bigger sense of relief, or but there's no, I would say, I'm not any more proud of that than the patient who gets pregnant right away. It's just emotionally harder the longer it takes.
Yes. And for those patients who may not receive the best result within just one cycle,
yeah.
how did you learn in those years to communicate best with them? Because I'm pretty sure there's some disappointment involved.
Oh yeah, there's a huge amount of disappointment for anybody. I mean, anything, people always ask me, after the embryo transfer, well, I'm going to be super optimistic or I'm going to be super pessimistic. And I always say, look, you can do whatever you want. If you're not pregnant, you're going to be devastated, because everybody who has a negative pregnancy test is devastated, and it doesn't matter how you approach it going in, it's devastating. And I think that the key is just, making sure the patients feel comfortable communicating with you. I think when they feel like you really care and you're really on board and you really are trying to do the best for them, that helps, that provides them with a certain level of support. I encourage patients to have lots of support, not just me, but support from an acupuncturist, support from a therapist, support, as much support as possible, because it is such a challenging thing to go through. And, there's nothing I can do to minimize, there's nothing I do or can do to minimize the devastation they feel when an outcome is anything other than an ongoing pregnancy. You just help support them, and I think that people often feel better once they know what the next steps are, so they take a moment to feel sad and then make a plan. Most people want to make a plan right away so that they can feel like they're moving forward, and that is the only thing that makes them feel better. But no one feels all the way better until they have a baby.
Yeah, I agree. So for those people who had received IVF before and didn't get a successful results, what do you think will be like the major things they can do, or their care providers can do to help them proceed?
Yeah, it just depends. I mean, everybody's different, and the reasons for not getting pregnant are different, and if everybody has different things getting in their way, and sometimes it's something that they can fix, and a lot of times it's not. People ask, that's another thing they ask, well, what can I do? What can I do? And a lot of it is outside of our control. There are little things that we can do. We know that obesity is bad for fertility. So if a patient's obese, we try to help them lose weight. We know that age has a negative impact on fertility, and there are some supplements you can take to try to improve egg quality, but the reality is there's only so much you can do, and sometimes it's just, doing more and more cycles to come upon the good egg. And there's really, oftentimes it's not the patient's fault. They haven't done anything wrong, and the other side of that is that there's unfortunately oftentimes not a whole lot in their control that they can do differently to make it, different.
Yeah. And what about for people who are not trying to get a baby right away, but as their age advances, they want to know if they have more options in the future? What's your recommendation for females like?
Yeah, I mean, I think we're doing this more and more as people, there's awareness of the negative impact of aging on fertility. Females are coming to freeze their eggs, and we're doing a lot more of this where, young women in their early 30s don't have partners yet or aren't planning to get pregnant, and they come and they either freeze eggs or they freeze embryos if they have a partner. And certainly that's not a guarantee of a pregnancy in the future, but it is the one thing that we have to offer people to try to increase the chances that they can have babies with their own eggs in the future.
So what is the most advantage for egg freezing?
We don't have like a cutoff for it. Certainly the younger you are when you do it, the more likely you are that those eggs would actually result in a baby in the future. The older you are, the less likely it is, because the quality of the eggs will be not as good. But it's different, and it's up to the patients if they want to decide it. So, in older women, 40 or older, if they want to do an egg freezing cycle, the first thing you want to know is what's their ovarian reserve. Are they going to make 20 eggs? Or are they going to make 5 eggs? And I'm not going to say no to the person who's going to make 5 eggs. She just needs to be aware that the chances that those eggs will result in a baby in the future are low. But if she still wants to try, we're not going to stand in her way.
Yeah, and for those who do not have a partner, do you say that we have more options for them if they do not have a partner but still want to conceive a baby of their own?
Sure. I mean, if you are a female and you're ready to start your family and you don't have a partner, then we talk to you about using donor sperm, and the different options for using donor sperm, and the different ways it can be used to create a pregnancy.
Yeah. And, do Do you think that's a good option, like to use donor sperm?
Yeah, I mean, I think if a female is ready to start her family and she wants to start it with, using donor sperm, it's a great option. Obviously, it's a very personal choice, but it's a great option.
Yeah, and we offer the option.
Absolutely.
Yeah, and how about for males? For if they want to be a father one day and they don't have an egg resource, they can search for egg bank.
Yeah, I mean, if a father wants to start a family on his own without a partner, same thing. He could use a donor egg. It's more involved, as you might imagine, than donor sperm. Donor sperm is ready to go. It's frozen. It's shipped to the clinic, and then it's easy to use. The donor eggs. Also, you can either use a fresh donor, where you choose a donor who has not yet been stimulated, and then that donor undergoes IVF, and the sperm is combined with the egg the day of the egg retrieval, or you can use eggs from a frozen egg bank, and the female's already been stimulated, her eggs are already frozen, and those frozen eggs can be shipped to the clinic and combined with the sperm to create an embryo. Obviously, this will also require a surrogate, right? So in females, again, it's less complicated because all you need is the sperm, but for a male, he will need the egg as well as somebody to carry the pregnancy for him.
And in the States, we do have people who cannot carry the pregnancy either for this reason or some other health issue. They can use the surrogates.
Yep.
Do you want to tell us more about it? Like, what's the whole process if I want to opt for a surrogate?
Yeah, so typically when someone's using a surrogate, there should be a reason for it. So we sort of feel that carrying a pregnancy has some morbidity, but these surrogates are incredibly generous and have decided that they're willing to carry a pregnancy for another person, even though there is some risk involved in that. So we start by, but some people have reasons why they can't carry pregnancies. They have cardiac conditions, or they've had blood clots in the past. There's a lot of different reasons why somebody may not be a good candidate to carry their own pregnancy. So what would happen if someone chooses to use a surrogate, they would be matched through a surrogacy agency, typically, unless they had somebody they knew who was willing to carry the pregnancy for them. If they're using a surrogate through an agency, our third-party coordinators would help them find a surrogate who we have screened and decided would be a good candidate to carry a pregnancy. The individual, the intended parent, would undergo an IVF cycle as we've described. Once the embryo is created, it's frozen, and then we prepare the uterus of the surrogate, and ultimately the embryo is placed into the uterus of the surrogate, and then hopefully she gets pregnant and she carries the pregnancy and delivers the baby.
Sure. And the other thing about the IVF in this generation is PGS, and it's a big thing. Do you want to explain this PGS to us? And do you want to tell your patients what's the most scary part? Because some patients think that, if my husband has something, my baby definitely will have this one thing. What are their options, and what can we offer as a care provider, some assurance?
Well, I think this is another common misconception with IVF, the purpose of the genetics testing. So what happens with the genetic testing that we do of the embryos is that a few cells are taken off and check which of the embryos that you have are balanced versus unbalanced. A balanced embryo has 46 chromosomes, and a lot of the embryos don't. They have too much or too little genetic information. And the purpose of that genetic testing is to tell us, okay, this embryo has the highest chance of sticking and the lowest chance of a miscarriage. It's really an embryo selection tool. It won't tell you, it will tell the gender, it reveals the gender of the embryos, but it doesn't tell you if the baby's gonna have autism or a heart defect. It doesn't tell you about the specific genetics. It just tells you the very big picture. So I think that again is a common misconception. It doesn't promise any of those things. It just is trying to maximize the chance that that embryo will stick by selecting the best embryos to put back inside the uterus. And again, the testing is very good, and it makes it so our implantation rates with each of these embryos is very high, but it's not 100%, and the testing is also not 100%. It's probably about 98% sensitive.
Okay, 98 is still high.
Very high.
Yeah. And for people who actually has some genetic disorders through IVF and through the PGS, can we find out what's the chances for this embryo to carry the allele?
Yeah, that's right. So if there is a known genetic disorder in a family that you're trying to avoid in the offspring, then we can absolutely look for that in the embryo. It's not done routinely, so it's not part of the general genetic carrier or genetic testing that we do in an embryo. But if a family has a known mutation that they want to test in the embryo, there's a lot of advanced planning. We'll need, blood from the parents to understand exactly what that mutation is so that we can prepare to look in the embryos and see which of the embryos carries that mutation and which of the embryos does not. And then you can ultimately pick embryos that doesn't carry that mutation and put those embryos back into the uterus and discard the others.
Sure, that was very accurate information.
Yeah.
And at the end of the day,
Because I have a super busy morning, I don't want to be late for it. So okay, 5 minutes, let's go.
Yeah.
so at the end of the day, we are enabling new life to be born.
Mm-hmm.
Then what makes you happy besides your work? Like what's your biggest joy comes from?
My kids. Oh yeah.
Okay,
Yeah.
5 minutes, you can talk about
5 minutes. Yeah, I mean, I think that the thing I care about most absolutely in the whole entire world is my family and my kids, and really all I have time for is work and being with my family, and at this stage of my life, the small children, that's all I care about.
Yeah. 太短了吧？
太短了。
没事儿，这样他先去去那个什么一下，完了回来我们还要拍一个镜头。
You can check your patients now.
Okay, yeah,
Can you
perfect.
come back later? We maybe need to do some still shots.
Okay, that's fine, but I have a super busy morning now, so let me just get through it.
Yeah.
So the next question is, why do you love what you do? You could have been any kind of doctor. Why fertility specifically? Tell me about the moment that you realized that this was going to be your life's work.
You never know what path in life you're going to take. What you do is you get off on a certain path and then you see what your interests are and where it takes you. I wasn't born saying I'm going to be a fertility doctor, someday. In fact, I didn't even know I was going to be a doctor. When I was maybe 6 or 7 years old, I told all my family and friends that when I was younger I wanted to be a doctor, but now when I grew up I wanted to be an astronomer. Because what fascinates me about life is science and exploration. And I wanted to be an astronaut. I wanted to be an astronomer to discover new stars and new planets. And I felt that way when I was 6. But I realized what was important to me is the human interaction. So I knew I wanted to be a doctor, from the time maybe I was in junior high or high school. But I certainly did not want to be a fertility specialist. In fact, what I wanted to be is I think first a radiologist or an anesthesiologist, but those type of specialties don't have much human interaction. The one thing I was sure I didn't want to do is I didn't want to do obstetrics and gynecology. The irony is that's the specialty that I ended up choosing. Because I went through all my rotation in medical school, and I went through dermatology and pediatrics and family medicine, ophthalmology. And the one thing I knew I did not want to do was obstetrics and gynecology, but I went through all the specialties and didn't like anything. But when I did obstetrics, I felt like that was really my calling, because it's very happy medicine. And it's a surgical subspecialty, so I can use my hands. And I play the piano, I like a lot of activity. So it was a combination of, being able to, use your head and use your hands. So I did my residency in obstetrics and gynecology, but at the time of my residency, this is when the first test tube baby started to come out. The first test tube baby was born, I think, in 1978. And I finished my medical training in 1983. That's when I graduated medical school. So there was a very narrow overlap between the first test tube baby and when I was done with my training, and it was such an exciting time in medicine. So after my residency, I decided to subspecialize in reproductive endocrinology.
Okay. So I have a question that sounds silly, but I'm curious about your perspective. Why do people want babies?
I don't think there's a good answer for that. I can give you my opinion, and I'm sure there are a lot of experts and psychologists and theologians and philosophers that have their own angle. My feeling, well, first of all, for the work that I do, it's a joy. I feel as though I have the best job in the world because you're helping people procreate, you're helping them with a family, and you're helping people who are really at almost a desperate time in their life to be able to, to have that child that they want so desperately. So I can help that, through my work. Sometimes patients are, needing an egg donor or a surrogate, but it's, the fertility work that we do touches our patients very deeply. It's very, very painful for couples to want something they can't have, especially a child. So the work is extremely gratifying in being able to help couples have something they don't want. And that's generally true whether they're buying a car, they're going out for dinner, they're buying a house. We all have, our walks in life where we're helping people, many people achieve something, but to be able to help them with something so fundamental as having a child, I think is really extraordinary. And I didn't realize that at the time. I didn't realize that when I chose the specialty. But I realize now how important our work is and how deeply it connects all of us. As far as why people want to have babies, that's...
I think they want to copy the gene. It's from the instinct.
Well, there are many reasons. I think I have 2 daughters, and I love when I look at them, and I love when they look at me. And that's a feeling that you can get with your friends, you can get with your spouse, but you get, and you have children, you get a very different feeling when you look at your kids. And you see yourself in them. So I think part of it is wanting to do something very gracious and altruistic, wanting to give to them something that you can provide, maybe wanting them to give them something that you didn't get as an adult. So you see your shortcomings, you see what you got from your parents, and there's some reparation in all of that. And I think it's very healing, actually. But the other reason for doing it, in a more humanity sense, is it's very, you want to leave a legacy. We're here on this planet for a purpose. We're here to help each other. We're here to make the world better. And what better way to do that than to pass that on to future generations, your children, with a certain set of values and a love for the universe, a love for humanity. And, because we're only going to be on this planet for, a short time. But our children and their children and their children will, that can go on in perpetuity. So that's our legacy. Otherwise, we stop as a species.
我觉得他这个就说的挺大的。
对，但是我是说，咱往下可以，就是他刚才说的这些内容，往下说的是，当很多的患者带着自己的孩子，带这些信息来找他，在感谢的时候，他的心情怎么样？因为他刚才说了，他对这个为什么生孩子，说了一些他的想法，然后他得有这个满足感和这
就是下一个问题。
那就是了。就我这个问题接着说。
So you've practiced fertility medicine for many years.
Mm-hmm.
What was the field like when you started, and how has it changed? What new technologies and new possibilities exist now?
That's a great question. I started to talk a little bit about why I went into the specialty. And at the time, it was a very academic and research-oriented specialty. IVF was just starting. So when I went into it, I didn't think I would be doing IVF. I thought that would be a small part of it. I actually wanted to do research and teach and do general fertility work. But since the first test tube baby, the whole process of IVF has just exploded and has dominated the specialty. So the specialty has become synonymous with IVF. You know, there are other types of treatments, there are other types of technologies. For example, you know, when I was trained, surgery was a very large part of, of what we had to offer patients. In fact, I would probably be doing maybe 10 to 15 surgeries, a week. Now I do about 10 to 15 surgeries a year. And the reason for that is because IVF is so much more successful generally than what most surgeries can offer patients. So the technology of being able to create test tube babies has just completely turned the field upside down in a very positive way.
So what hasn't changed over the years, and what always remain the same in the field?
Well, the science has changed dramatically. The way we practice is very different. How we counsel patients. And what is nice is the success rates are always getting better and better and better, and our patients are the beneficiary of that. So I have to say to all our patients, and I couldn't say this 10 years ago, most all of my patients under the age of 35 to 37 get pregnant the very first time we do this. And that's really, really nice, especially when the treatments are very emotional and very expensive. But what hasn't changed is the human factor. People's need to, want to have a baby. The angst associated with not being able to have a child. In fact, when it doesn't work, which I have to say at our center is actually more unusual, their anxiety is higher because their expectations are so high. And they should be, because most of the time patients will have a good outcome. So I would say it's the human component will always be the same in what we do.
So tell us the proudest time, the moment in your career so far.
Well, it's day to day. It's day to day. And I would say, the proudest was yesterday.
Yes.
And the day before. And the day before that. And last month. Yesterday, I was out at the movies. And there was a patient who came up to me to say, Dr. Hubert, let me show you a picture of my baby. And I knew this patient really well. And she had tried for many, many years, and she had been to several other centers. And she got pregnant very quickly.
Yeah.
Yes, with me. And she looked beautiful, and her baby looked beautiful. And that's the proudest moment that I can think of within the last 24 hours. But that happens almost daily, and the day before, and the day before, and the day before. Very seldom am I out in public where I don't see somebody, And it's nice because I don't have to wear a baseball hat. I don't have to, travel incognito. People aren't asking for my autograph. But you see the people in our community that we've touched.
就是不是说的特别细节的东西。
我其实是要，我是感觉能不能稍微再感性一点，说的那时候内心的一些。
他真的是明白，这个只能让另外一个医生。
那就
他不是，然后
不是那种。
不是那种医生，他就是非常抗拒。所以我也想问一下他。Okay, the next question. 我还有2个问题 I just have 2 left.
That's all?
So, what your children think you do? How do you explain your job to your kids?
How do I explain my job and how do I explain it to my children?
Yeah.
The sound?
The sound
Yes.
is turning off.
那这个能不能再开开呀？因为我们这个声音得一致。
但是环境特别安静。
那个，你说那个。
The problem is if you readjust, it may come on again in 2 minutes.
OK， 那就它一会儿还会开的。
2分钟。
要不然等它开了，再不是一会儿录一个空的。
当腰不控制。
你拿那声音比一下，能治一下。
去电它。
你说的吗？
我们说要空调。
2分钟以后就开的是吧？
它温度到了，它就停了，然后等会儿温度不到，它就又开了。
要不然等它温度到了。
那我得把它调低一点去。
我一会儿我们录个空的，去电这个。
Yeah.
那就算了，那我们就开始。
Air fine.
It may come on again in a couple minutes. Okay.
Just tell the story.
Okay. When I was younger and I had just had children, you start explaining what you do to your children, and I explained to one of them that I help people have babies. So our daughter went to school for Share Day, and you talk about your family. And they said, what does your dad do? And she said the equivalent of, my dad has sex with a lot of women. And they said, what are you talking about? Well, he helps people have babies. And then they figured it out over time that your dad must be a fertility specialist. That was when they were young. Now, and actually you were asking me about my proudest moments when I brought my daughters to the office here and I showed them the laboratory. And you can see where all the magic happens. You can see the eggs and the sperm and the embryos and how everything comes together. And what's fascinating for me in explaining it to my children is it's amazingly humble work. And the more you know, the more you realize how little we do know about all of this. And when you think about all the everything that has to happen for you to be here, for me to be here, for us to be having this conversation, it's miraculous we're having this conversation. And how you can put a sperm in an egg and turn it into a human being is unbelievable. It is. Yeah. It really is. Yeah.
So the last one. Yeah, the questions I really want to know. You are known for always taking a very calm, very steady approach to fertility that gives a lot of patients a sense of comfort and security. We all know that this practice has its ups and its downs, its challenges as well as its joys. How do you keep an even keel throughout the process?
Well, I think when you're counseling patients that are going through a difficult time, people want to know, number one, that you're going to be there for them. They're going to want to know that you're going to do everything technology possible to give them the best chance for having a baby. And they also want to know that you're fair about your statistics. You're going to be honest about your work. So I think, patients want to know that you're going to be there also every step of the way with them. That good or bad, and that's the nature of this work. You don't give everybody good news all the time. We give most people good news very quickly. But when it doesn't work, it's really important for you to objectively look at why they're not getting pregnant. And they want to know that if it doesn't work, you're not going to fall apart. They want to know that you're the one that's going to be the rock that's going to stand there and say, no problem, it didn't work, we have another answer. And if that doesn't work, no problem, we have another answer. You can't help everybody 100% of the time, but people want to know that you're the one that's going to be able to guide them through this. And they don't want a guide who's going to be erratic or, non-supportive or unavailable. And a lot of the stability that I get comes from the science. It's the methodology. And that's the other side to what we do. There's a very human aspect, and I've talked about that a lot, but there's also the science. And science dictates, a certain approach. You can't do good work, you can't do good research, without an analytic mind and without, certain objectivity to what you're seeing.
That's good. Totally different from another person.
He's a good doctor too, though. He's different, but his patients really love him too. They really like him, and he's very, very good, and he's very bright. Yeah. We have very different personalities, and I think we get to the same place.
We cannot judge yet right or wrong.
And Dr. Schmucky, everybody is different. Just like musicians, everybody's different, and that some people can be very successful with different styles, architects, entrepreneurs, business people.
So just one more.
Yeah.
At the end of the day, we're enabling new life to be born. So what makes life beautiful to you? Outside of work, outside of everything, what makes you happy?
That's a hard one, because there are many things that make me happy. And what makes me happy, it's interesting, what makes me happy on one day may not give me satisfaction another day. So it's important to find different channels to give you satisfaction. It's family, it's my wife, my daughters, it's my music, it's athletics, and then of course it's the work. It's having a purpose, I think, in 2 or 3 or 4 really important areas where you can make a difference.
So you have people build up family because you give them babies.
And that's, to me, that's the joy of our work.
That's the joy part.
You can give people different kinds of gifts, but the gift of a baby is just, it's indescribable. Yeah.
Good.
Yep.
Very good interview. I know you better.
This is a very small gallery of some of the babies that we've helped create through our work. And actually, we probably have helped maybe thousands and thousands of babies, but over the years, we just simply ran out of space, so we stopped putting up pictures several years ago. And also, what's the oldest patient that we've been able to help is a woman who was 48 years old who had struggled for probably for 2 to 3 years, and she was convinced that she would need an egg donor, but she ended up getting pregnant, with her own eggs. Over the years, we've helped many, many couples have babies. One of the reasons why this is on the wall is because this was the first testimonial for a patient who's been able to have a baby through our help. This baby was conceived and delivered in 1991 and 1992.
2, 3 ER son.
Okay. We're ready? Okay, here we go.
手你就做指就行。
好的。
对，尽量别动。OK，我们好了。
Okay, let's start.
好。
So the first question. question that we want to ask you is, why do you love what you do? You could be any kind of doctors, but you choose fertility as your specialty. Tell me about the moment you realized this is going to be your life work.
I think that at one point I was considering doing something we refer to as perinatal medicine or high-risk obstetrics. Right about that time, the fertility world began to really explode, primarily with the advent of in vitro fertilization. So at that time of my career, which was in the very late 80s and early 90s, that influenced me profoundly. Because up until that point in time, there were many avenues that were closed with fertility. And so with the advent of IVF and some of the newer technologies, it looked like it would be a specialty that would be constantly expanding. So it was very young, and you could make a lot of contributions at that point in time. So it was a very exciting field, and I don't regret my choice.
So when was the moment that you realized that you will stick with fertility and you don't want to switch to other fields?
I don't know if I can recall a specific moment. I can recall what time of my life when I made the decision. I think I was influenced by a couple of my mentors when I was in training. They seemed to be people that I admired, and they were very excited about the future. And so I think it would probably be a period of time as opposed to one instant point in time.
That was great. And since you choose this career, can you tell me the moment that you're most proud of during your career as a fertility specialty?
It would be difficult to say what I'm most proud of. I would say that I'm proud of many aspects of our profession and of our practice. I certainly think that you're constantly reminded of the contributions you're allowed to make by the feedback you get from patients. Even 5, 10, 15 years later, you get correspondence from patients telling you how your actions influence their lives greatly. And I suspect probably a disproportionate amount of positive feedback in this profession compared to many others. I can't really say that that's what attracted me to the profession, because as it's evolving, it's not something that you expect. But it's certainly an unexpected and much appreciated benefit that comes with the subspecialty.
Sure. And we know that every doctor has their own style and approach to fertility treatment. And yours is a lot about building a bond with the patients. It's not just clinical, it's emotional. What are some of the challenges and the joys of being emotionally invested in your patients? Do you personally suffer when the treatment is unsuccessful if the patient comes to you for help?
I would say that I absolutely do. And in fact, I would say that's one of my character flaws, in fact, is to be too emotionally invested at times. I also think that the nature of the specialty has evolved in that it used to be 20 years ago. There were couples or individuals that had certain problems which could not be overcome with any technology that existed. So now, with the ability to genetically screen embryos, to have gestational surrogate carriers, to have egg donation and so forth for couples or individuals who may need them, essentially virtually almost every individual or couple can be successful. Having said that, it still does not mean that in individual circumstances it's a very long journey and some very emotionally challenging. So it's certainly a specialty that has extreme highs and it has extreme lows. And so it takes a certain type of personality to negotiate those waters, because it's not for a person, it's not a specialty in which the emotional temperature of the interactions stay relatively constant throughout the week or throughout the day. It's a specialty of extreme high in joy and extreme disappointment from time to time.
Do you mind tell us one of the moments that you can remember when you are facing this kind of disappointments, and
Well, I think that what I try to do when I first meet with an individual or a couple is to come up with what I call a sort of a triangle of therapeutic options. In other words, what I typically would do is when I meet with a couple, I typically try to come with a pyramid of what the options are going to be. And I think one of the most difficult things is not knowing, you know, I don't know if I can draw 4 backwards, I don't do it often enough, but not knowing what the choices are going to be floating, so to speak. I think most people prefer to know, I'm going to try this, and if this is unsuccessful, then I'm going to segue to this. If this is unsuccessful, then we'll try this. And if this is unsuccessful, I suggest you do this. Now, many individuals or couples won't choose to go all through the different steps should they need to, but I think it's best to sort of set a treatment paradigm of what the different options are. I find it personally, and I find it professionally very difficult to float. In other words, to say, well, let's try this, and if it doesn't work, check with me again, we'll come up with a plan. I like to come up with a plan that is kind of encompasses all the different possibilities. I think what's particularly disappointing sometimes are individuals who have a very good prognosis or have a prognosis which you think is very reasonable and it isn't successful and you can't really identify what the factor is. I think it's much easier to understand if you know what the problem is and you know your probabilities of success or A or B or C, but it's very difficult for the patients with an extremely high prognosis who have very high expectations and then for them to be unsuccessful. I find those very particularly challenging circumstances.
And you suffer from that?
Well, I think it certainly leads to a lot of emotional discomfort.
I remember there is a girl and you put her picture on a table and I saw that you were in tears, remember? And she died from breast cancer.
Yeah.
And put her picture with her children's picture together. And this happened a lot.
Well, we do see patients now because the different options for fertility preservation, the different options now are, for example, it used to be when I was at UCLA in my early part of my career, we would see young women that had leukemia or different types of malignancies that would frequently be curable. But the cures involve chemotherapy and radiation and treatment modalities that would render them infertile or sterile, or it would basically eliminate their cohort, their supply of eggs. So that was very difficult talking to a 22-year-old 25 years ago who's faced with either not getting treatment and dying, or even if she does get the treatment, knowing that there's a meaningful chance she may not be cured. And oh, by the way, if you want to have a baby, then you need to get donor sperm when you're 22 and make embryos. Now, we have the ability to freeze eggs even for individuals who have a very, who are going to be getting very aggressive chemotherapy. They can freeze eggs, and then we could actually vitrify eggs, but they can separate, so they can save eggs for some future point, even 10 or 20 years later. But unfortunately, a subset of these individuals who are getting this aggressive treatment are not going to survive the treatment. It can be very particularly challenging.
And what happens to you before you were working with one of those subsets of patients?
Yeah, we do see that. I do see that subset of patients, yes. But less and less, I will say, less and less. I.e., the treatments to cure the malignancies are getting dramatically better in virtually all the different areas of the oncology world, fortunately.
So I wonder if you would like to share that yourself actually had children that is being conceived with IVF technology. Do you want to tell us about the experience from a father's perspective rather than a physician? fertilization?
Yes, in fact, I have 3 children, and all of my children are the result of in vitro fertilization. And in fact, we tried other therapies before IVF, which were not successful. And we did IVF in an era where the technology was less advanced than it is now. And so I've had cycles which have been successful and unsuccessful. So I'm quite familiar with the concept of taking fertility medications, watching your partner go through an egg retrieval, waiting for the fertilization results, doing an embryo transfer, being very excited, and then getting that phone call or the result, and it's very binary, i.e. it's either very yes or very no. So I've seen it be successful and experience that thrill, and I've also seen the opposite happen where the results were negative, and it led to, a lot of sadness and unhappiness. So I'm quite familiar with it. I'm quite familiar with mixing medications up late at night. I'm quite familiar with giving progesterone and injections, and I'm quite familiar with it from both a provider's point of view and also from a recipient or patient's point of view.
And as a father of IVF babies, like, what's your feelings about those technologies? Do you have great gratefulness that we are now able to do this?
Oh, absolutely, I have gratefulness, and in fact, I would say that in the demographic that I live in most urban areas in the United States and most countries, it's very common for couples to delay childbearing until the female partner is over 35 years of age. So I would say that in the circles of people that we interface with, my children's peers and their families, a very high percentage of individuals have been from in vitro fertilization. I remember being in one of my children's kindergarten or first grade classes. There were 25 children in there, and 8 of them were my ex-patients, and the majority had done in vitro fertilization. So in this era, a higher percentage of conceptions are in vitro fertilization. I believe it's about 2.5% to 3% nationally, somewhere in that range. But it's very skewed in urban areas where people tend to delay childbearing for a longer period of time. It's much higher than that. And in areas in the country where people tend to start their families when the female partner is under 25 or under 28, it's only about 1 and 1.5%. So I'm very grateful, but it's becoming almost like other technologies. It's becoming sort of the standard of care, if you will, and it's becoming ubiquitous and not novel. And I think a lot of people are very comfortable talking about it, sharing their experiences, more so than they were, say, 15 or 20 years ago.
So, what are the most common concerns people may have? What are the most common misunderstandings? And how have you learned to communicate best with those patients who has a lot of misunderstandings through this whole process and the concept of IVF?
I think that one of the concerns people used to have in a different era, and much less so now, was that did this technology put my body at risk for problems later in life? And I think because although the first IVF delivery was in 1979, so what is 39 to 40 years ago now, it really wasn't a widely practiced modality until about 1995. Then exponentially the number of cycles went up. So now a lot of those women that were 35 to 44 that were doing IVF 25 years ago, they're now, 65 to 75, particularly in places like Europe and Australia where they have national databases and registries where they can follow patients' health care. It's very clear that it doesn't put women at risk for increases in medical problems. So I would be asked that very commonly 20 years ago, do you think this would increase my risk of breast cancer or some other type of health problem? I get asked that very infrequently. Conversely, I think the misunderstanding that a lot of individuals have is that if I have eggs, then therefore I should be able to have a baby very routinely. The concept of being 43
and looking good and feeling good and being very healthy and having 6 to 8 eggs potentially, and being a person who's 33 with 6 to 8 eggs, that the former group has a much lower pregnancy rate than the women that are 8 to 10 years younger, but they have the same number of eggs. The concept of an egg fertilizing, making an embryo, and being genetically abnormal is still a difficult concept to transmit. Fortunately now, because of the options of doing the genetic screening, which we have widely available, we can show patients, we can demonstrate this is what the results were. And it's more tangible. One's kind of conceptual. I'm getting older, my fertility is less. But when you can see the results, oh, this is normal, this is not abnormal, I think it's much easier to process. Because in the past, what did we do? 15 years ago, 10 years ago, the older the woman was at the time the eggs were harvested, typically the more embryos or blastocysts that we would put in. Now we can enjoy the same pregnancy rate putting in one, whether you're 44 or 24, so long as you can identify an embryo which is genetically normal. So that's probably been the biggest evolution. What's coming, and it's going to come much sooner than later, is the following. The Human Genome Project, which I believe is around 2004, 2007, I believe they sequenced 4 or 5 individuals. I think it was 4. It was roughly $1 billion per person for the technology. So in a relatively short period of time, certainly less than 15 years, the price has fallen to do a whole genome sequencing has fallen to something like $1,500, $2,000. So although we have about 3 billion genes that give us all of our characteristics, only about 30,000 genes actually make the proteins and enzymes which give us all of our characteristics and make us what we are. So it'll be, I think in relatively short order, you'll be able to do whole genome sequencing for each embryo, and they'll be able to code for the 30 or 40,000 genes which are the most important. So that'll be the first step. So once you're able to do that, and people can accept that pretty widely, oh, if you could screen for cystic fibrosis or things which we consider abnormal, people welcome that. It's the rarest of individuals that would find that to be distasteful. Then the next thing will be complex situations like type 1 diabetes, where you have multiple genes on different chromosomes that get turned on, they get turned off, and they communicate. So I think it's going to be more complex than just identifying those 6 genes, but I think eventually some of those interactions will be understood, and potentially you can even do some gene editing, gene substitutions. But I think where the transition is going to become more tricky is going to be, what do you do with too long? Is the microphones?
Yeah, like this. Okay.
Is that better? Okay. So I think where the concern is what the future, how you can use technology effectively. And I think what a lot of people object to is the concern that you could do gene editing for certain physical, we call it phenotype, physical characteristics. So let's take an example, gender balancing. There's a subset of people that find gender balancing something that they object to. Most people don't. Most people feel like, well, if a person wants to have 2 girls, it's their prerogative. If a person has a girl and wants a boy next time, it's their prerogative. But there are a few people that find that to be something that they have trouble with. But as you go down the continuum of what would be normal, let's imagine if you fast forwarded 25 years from now and you had the ability to do gene editing. So let's say eyesight. Most Homo sapiens, their eyesight is about 20/20, when they're 21 years old. And then over time, it begins to deteriorate. But there's a subset of people whose vision is 20/10. That means that at 20 feet, they can see at 20 feet what you and I can see at 10 feet typically. So for them, that's normal. But imagine your baby, you could do IVF, And you could do gene editing. You could take out one gene and you could put another gene in, so your child would be born, it'd have 20/10 vision. A subset of people go, whoa, 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 20/20 is natural and normal, 20/10 is not natural. Other people go, wow, that'll make my child's life better. So it'll go incrementally. And then the next step would be, what about other characteristics? What about the color of your eyes? What about the shape of your lips? What about the size of your ears? What about vertical height? What if there's four? So it will go incrementally. But I will predict that within less than 100 years, the world as we know it now will be radically and completely different. Radically different. And I believe there'll be fewer people on earth, because I think there'll be more prosperity. There won't be the same need to have 5 or 6 or 7 or 8 children if you live in a poor country. And what we consider normal will change radically. And I do believe that people will manipulate their genetic code. I do believe that people, if there's something they can do, there's a subset of people that will keep pushing it and pushing it and pushing it. And people will protest at first, but eventually it will follow. I feel that that's an absolute. For example, something like 1% of human beings are immune to retroviruses. Retroviruses are uniformly very bad viruses. They cause HIV, AIDS, they cause rabies, they cause a lot of nasty diseases. But for some reason, about 1% of people are immune. So if you find that gene, and you can take that gene out, you're doing IVF, and you put a gene in so your baby can't get rabies if he's exposed. And then suppose you can do malaria. Like now we do vaccinations for measles, mumps, rubella. We don't think anything about it. When that was first offered, people protested violently. Could cause all these horrible things to happen. Now it's accepted. So I do believe within less than 100 years, human beings as we know them will absolutely manipulate their offspring. And I believe, again, not necessarily for better, I think a high percentage of conceptions will occur synthetically. They'll occur artificially. I really do.
So for our fertility clinic, we have a really high rate nationally for the live birth rate. Do you know why we are so good at it? Like, what's our?
Well, I think a lot of things, they're fundamental things. You have to have skilled people handling tissue. You have to have skilled people handling tissue. Period. And then and you have to have a certain amount of quality assurance. You have to have, for example, things which are fairly mundane. You have to have your air filtration system has to be superb. You have to have people that handle tissue very quickly and adroitly so that the pH, the temperature stays very uniform. So there's lots of little modalities, 2% here, 3% here, 3% here, 2% there, which cumulatively give you a big advantage. And I think sometimes it's very difficult to really explain pregnancy rates accurately, because there's a subset of patients who have a very poor prognosis that they actually want to try repetitively, even though their prognosis is very poor, without moving on to another modality. And some clinics have a policy, if it doesn't work 1 or 2 times, you either have to go to an egg donor or a surrogate, or you can't go anymore, or we don't have that. So if you took those patients out, the pregnancy rates would be even more satisfying. Microphone slip. Do you want me to raise it up a little?
Yeah. No. Just outside.
Just on the outside? I can put some clear tape on there too. You want some clear tape? Do you want some? I can put some.
Okay.
You know what? This might help you. How about if we get some clear tape? I had some. What's on the desk? Okay, we're good. We're good. We're good. We're good.
Yeah, and you were saying that our high pregnancy rate and the live birth rate was because
it's because of expert tissue handling, and also because I think of selection bias, genetically screening the embryos, but also I think people who handle the tissue adroitly and having attention to detail. because it can just be if you have people that don't handle the tissue rapidly and don't do things efficiently, things can begin to drift. And I think you have to have a lot of internal quality control issues. You need to constantly analyze your data. You need to constantly, with the fertilization rate, the cleavage rates, how well the embryos are developing, you need to constantly check, and manipulate. It adjusts along the way.
And at the end of the day, we are enabling new life to be born. That's what we do. What makes life beautiful to you? Outside of the work, outside of everything, what makes you happy?
Personally or spiritually?
Both.
Both? Well, I think personally I enjoy being with my family and my friends. At the end of the day, you know, your family and your friends are really all that ultimately matters. I mean, if you're able to command amazing amounts or remarkable amounts of material wealth, theoretically, it allows you to help other people and to spend more time with your friend and your family. And so I think that's really what I crave the most. And I think with modern life and our children and our friends having lots of commitments, I think that I get the most satisfaction out of that. Personally, I like physical things. I like exercise. I like golf. I like sports. I like to read. You know, I like to study Mandarin and Spanish. You know. So, but I think those are the big players.
Sure. And then even if the Mandarin is really difficult, you still feel yourself enjoying it?
I actually really do. I've often wondered why that is. There's something about Mandarin, the characters, it's the artwork. 1 in 5 people on Earth speak it, so there's a reason to that there's something to it. Yeah.
能不能让他这水彩的，就让他介绍一下他的一些奖。在菲尔就是最 proud of。
最 proud of 的
奖。完了以后再介绍一下这些都是。
当然可以啊，他都很喜欢。
对，就是我觉得这个再弄一下 OK。
一会儿马上你让水彩吧。
对 ，OK， 看。
And there's one behind there is kind of an interesting one.
我们会拍到这里。
If you can move the lights later.
Yeah, we can do that as our different shooting. Yeah.
Ready?
Okay.
开机了哈。
好来。
I can do one behind. Ready? So, these are just some various awards that I've received over the years, some recognition from typically my peers. Most of these are picked by other physicians, and they nominate doctors who are leaders in their fields. So some of them are America's Best Doctors, Super Doctors. This is an award from the University, Yosan University, that teaches traditional Chinese medicine in Los Angeles, and they selected 2 leading reproductive endocrinologists to come and speak to their class on several occasions, which I've really very much enjoyed. Over here is an award I received in Beijing in 2015 when I gave a lecture at the Beijing Fertility Association. It was a lovely event, a magnificent building. One of the more spectacular auditoriums I've ever spoken. So over here is an award that I'm very proud of and received quite a bit of attention from. This is from a magazine known as Good Housekeeping Magazine, which is a magazine with one of the larger circulations in the United States, and it's geared to the consumer. And they selected physicians who participate in different facets of women's health, and that was a fairly, I think the other physicians that were selected I consider to be quite elite. So I was very flattered and honored to be included in that group of physicians and providers.